All right, so the next speaker, a privilege to introduce Dr. Martine Extermann from Moffitt, a true leader in geriatric oncology, former president of SIOG, former winner of the B.J. Kennedy Awards, going to talk about assessment of aging from bedside to the bench. Martine.
Okay, I have some cheerleaders in the back here. Okay, so what I've been tasked to do is talk about the assessment of aging from the bedside to the bench and how we can use that in oncology. And as we know, age is a number. And that's often attributed to Mark Twain, but in preparing this talk, I realized that the truth of the matter, according to one of these fact-finding websites, is probably some anonymous geriatric researcher from the 60s who coined the sentence. Okay, but what the idea here is that, okay, calendar age, as we know, does not reflect biological age, or very indirectly. And so how can we get a better sense of how truly old a person is? So I'm going to organize my talk from the most clinical to the most lab, since we are going from bedside to bench. And at the end, I will tease your mind with asking the question, is aging reversible? Okay. The geriatric assessment, I'm not going to spend too much time on it because Stulishman just told you about it, and there are some very good, recent, comprehensive reviews. These two SIOG articles, we did a huge work, especially the Belgian group was at the forefront of reviewing all the systematic reviews for these articles, and they're very well funded, detailed about which geriatric instruments work, how they have been validated, which screening tools are available. So really go into that in detail and check out. What I would say is we need that. Okay, the question is, why use that? I know how to estimate a low patient, but Stulishman spoke about life expectancy, and in the questions you had to answer. But when you do ask physicians to estimate the life expectancy of a patient who is 70, well, the truth of the matter is that most of them underestimate by about 10% that life expectancy, but it can vary a lot. So one of the ways to estimate life expectancy is a series of tools that have been developed by geriatricians that are well validated and can give you, with a risk score, the mortality rate at, for example, 4 years in that example. And this is one of the well-validated score by Lee. These scores, you don't need to learn them by heart, because there is a geriatric website that's called ePrognosis, where you can go for 5-year survival or 10-year survival prediction, and it gives you a pretty good idea for an individual patient about what their life expectancy is, which is especially important if you look for adjuvant treatment. Cancer in that score counts for some points, but usually I try to estimate the prognosis outside of the cancer, so I kind of don't count the primary cancer, because I will estimate the survival of the primary cancer more precisely than the score does. But that gives you, outside of their cancer, what would be their life expectancy. You have to remember that increasingly cancer is becoming one disease among others as far as survival is concerned. This is a compilation I did a few years ago of several articles to try to tease out what is the 5-year survival of various diseases. It's very easy to do for cancer patients. You go to the SEER registry website and you pull that out. Believe me, it's very hard to do for the other diseases. even if you have a better prognosis with early breast cancer than diabetes, okay, at 5 years. Stage 1 non-small cell lung cancer is better than having a stroke. Okay. It's still, metastatic cancer still has a worse 5-year survival than most diseases, but increasingly we will have to weigh the cancer against other diseases. So, can we estimate with some more precise testing, what we call the functional reserve of a patient? My definition of aging from any clinical point of view is it's actually a decrease in functional reserve. Okay? All the research has shown that the baseline function of many organs is very similar in older patients than in younger patients. We have a very good homeostasis. For example, for a long time, people thought that anemia was a correlate of aging, but when people looked at it, it's actually a correlate of whatever comorbidity comes with aging. If you take very healthy seniors that don't have diseases, the hemoglobin remains exactly the same. Okay. However, what decreases is the functional reserve, is that you can't stretch the organs as far as you used to do when you were 20. Okay. So if I put that in a graph, this is how it works. We lose our functional reserve progressively with age. At some point, we become frail, which means that we use all the functional capacity of our organs just to maintain our baseline, and when we go below that, we die. So if you have a cancer, a surgery, a chemotherapy, you tap into the functional reserve of an older person, which may already have been altered somewhat by the disease itself. And 3 trajectories can happen after their acute event. The good trajectory is they go back to their baseline, they recover completely, and they keep going. What is often another possibility is they recover only partially to their previous functional status, and then they will keep aging on a parallel line, but they will have, following this acute event, an increased risk of disability and death. And then you have the unfortunate patients who crashes after your treatment, which we all have experienced. So one of the challenges of geriatric oncology is indeed to tease out who is going to go in these different trajectories and hopefully bring the C to the B's and the B's to the A trajectory. So here is an example of how functional reserve can be tested. And it's a very simple way. It's the gait speed. You make people walk on a 4-meter timed walk, and you measure the time they take, and you calculate their gait speed. And there is a beautiful, very straight relationship between the median survival and the gait speed. So the faster you walk, the more likely you are to live long. Okay? So think about that next time you rush to catch your next airplane. Of course, if you can't walk fast, you can use some help, and this is what a biker bar looks like in Florida. Okay, so you can do direct physical function test and functional reserve. The other examples of the timed up and go that Stu Lichtman showed for pre-op. What about frailty index? Can we measure how frail patients are? So frail patients are patients who kind of lost their functional reserve. And this is a beautiful slide I borrowed from the ASCO University. And this is essentially what happens that leads to that frailty. There's cellular senescence, organ senescence, which is modulated by gene variation on protection and longevity genes. Inflammatory diseases also contribute to impaired physiological function. Inflammation is bad for you. in general. Lots of studies on these interleukin-6, for example. Interleukin-6 increases with age and contributes to the fragilization of the organism. There are other factors, insulin-like growth factors, DAP, androsterone, sulfates, sex steroids, neuroendocrine problems that lead to problems in cognition, alteration of immune function, sarcopenia, osteopenia, and finally to a clinical pattern of frailty, which is slowness, weakness, weight loss, decrease in activity, and constant fatigue. So how can we capture that in a clinical setting? Before I go to that. So we age, we become more frail when we age, but it's important to remember that even very old patients are not always frail, okay? And if patients in their 80s and 90s, we still have only less than half of them who are frail. The other half is not, okay? That's frailty criteria, but it's reproduced. So we have to remember that when we treat older patients, not all of them are frail. You still have to distinguish and tailor your treatment.
Can you go back?
Yes?
This is astounding that 85 to 89, that men are
Right.
less frequently frail,
Yeah.
and that thing changes drastically in 90 plus.
Right.
Something happened at between 89 and a half and 90.
This is just one study. I think there might have been some, statistical. I don't remember how many patients they had in each of these groups, but yeah, it may be that the frail women in 85, 89 died by the time they reached 90.
No, but if you want to teach us about this,
Right.
and this is a very amazing study, because look at 80 to 84.
Right.
They are equal. And then suddenly there is a jump, and then there is a somersault.
Right.
So something is all right. Thank you.
You're welcome.
One reason cardiovascular is probably because a lot of men have died before the age 85. So you had a selection of very healthy men.
You are very kind.
I'm kind to myself.
So the question is, frailty, okay, in geriatrics, that's fine, but does it matter to oncology? So this is a slide that is a composite of 6 lymphoma studies, and or 5 lymphoma studies, actually. And they essentially used definitions of frailty. They classified patients into 3 categories: fit patients, a vulnerable patient, and a frail patient, and or sometimes 2. And they looked at how does it affect the outcome of their lymphoma. Okay, and you can see that these studies are very concordant. Here I go. You have a group here which is the healthy group, and they do pretty well with CHOP, Rituxan type of regimen. They all end up with the expected survival that you would have. However, the various definitions of frailty that have been used that are mostly what we call Balducci-like criteria, I'll go back to that. These patients have a markedly worse survival, and it's a pretty concordant thing. You can see that for all these patients, the median survival is between a year and 2, compared to not rich in the patients who are not frail. So these definitions of frailty are really relevant to oncology patients. So in all these studies and others, how was frailty defined? I put a list here, and you can see that in oncology, a lot of investigators have used an age above 80 or 85, either ECOG 3 or 4, or dependence in basic activity of daily living. Comorbidity, mostly rated with a CRSG. The CRSG, for those who are not familiar, is a comorbidity rating instrument that is very much like the common toxicity criteria we use in oncology. You rate every disease from a severity of 0 to 4, 0 being absent, 4 being life-threatening or very severely impairing. And you can put that in organ categories, just like you would do with common toxicity criteria. So the big advantage is you can rate any comorbidity in that system. And just like with toxicity criteria, we tend to think that comorbidity 3 or 4 are severe. Comorbidity grade 3 or 4 are severe. So here they use 2 or 3 grade 3 categories, or 1 grade 4 comorbidity as a definition of severe comorbidity. The presence of a geriatric syndrome also is often included, which can be frequent falls, dementia, incontinence, abuse and neglect, and others, these classic geriatric syndromes. And what was the outcome in these studies? Well, the couple used that simply as a study inclusion criteria. Others looked at the response and survival, like the Tucci study I just showed. Some studies used that to stratify chemotherapy, giving lighter chemotherapies to frail patients. Surgical series, it's not only chemotherapy series, it works in surgical series to predict 30-day complication. AML, and here this is a general cohort where it was associated with 2-year survival. So this set of criteria is very close to an idea that Lodovico proposed in 2001. This is why they are called Balducci-like criteria. He essentially pulled out from the literature an example of what frailty would look like. And that was kind of an illustration. We did not validate that. And for 10 years, we decided, no, this is not validated. You do things that are validated and so on. But as usual, the Italians don't listen to the Italians. So the Italians did the studies with Balducci-like criteria, and they showed what I showed you in the previous slide, which is that indeed there are associations with outcome. So I flipped 180 degrees now, and they say among the various definitions of frailty, that is one that seems to have some substance to it when it comes to treating cancer patients. These are not the only frailty criteria. In geriatrics, actually, the best used criteria are what we call the Fried criteria. And it's an unintentional weight loss of 10 pounds per year or more, Greek strength in the lower 20% of gender and size of the person, exhaustion by self-report, a walking time in the slowest 20% by gender and height, and a low activity during the week. It's a very respected criteria. It's not a gold standard. It's a silver standard because Fried says it herself. It's recognized as a high-risk group, but it's not a physiological definition of frailty, let's say. But it's not exactly easy to use in practice. Okay. So there is an interesting set of criteria that could also be used very easily in a clinical practice, which are those of the study of osteoporosis fracture. And this is an intentional weight loss, again, of more than 10 pounds or 5%. An inability to rise from your chair 5 times without using your arm. So you can do that in any exam room. Get your patient to cross their arms and raise 5 times, if they can or cannot do it. and then a low energy level per patient report. And if they have one of these three altered, they are vulnerable. 2 or 3, they are frail. And that correlates very, very well with the Fried criteria. So if you want to use a geriatric validated instrument, that's a very easy one to use. Let's go a little more in the lab general direction. Some people have tried to define frailty statistically. And so they say, okay, take any large number of items that one is something that is deleterious. 0 is the absence of that deleterious factor. Let's say falls, hypertension, poor hearing, abnormal glucose, whatever. Okay, and interestingly, if you divide the number of pathologic items by the total number of items, if you are above 40 items that make sense clinically, it's a very stable ratio predicting mortality. Okay, and the median of the robust patients is 0.1, frail 30 and frail 44. So it looks much more, physiological and statistical. Clinically, it's a bit difficult to grasp, but that's out there. That's another way that people define frailty, as a cumulative accumulation of health problems. Some people go even more towards the lab, okay, since we are going from the bench to the bedside to the bench. And they dosed in a lot of details various laboratory and physiologic parameters, and looked at the high-risk quartile cut points. And when they accumulate that, each point has a 10% increase in the relative risk of frailty at 3 years. So these physiological alteration, laboratory alterations, do predict the risk of frailty. So if you want to go above in amount of frailty, then you can try to see who is going to at high risk of becoming frail. So that leads me to the next chapter. We have all sorts of assessment, all sorts of index. Could we find a test that tells us the biologic aging of the patient? Could we just order a CA15-3 or PSA and find a marker of aging? People have looked, of course. And before I tell you what they found, I'd like to go a bit deeper in the biology of aging and cancer. Aging and cancer have a yin and yang relationship. Aging is at the same time a protection against cancer, and it is a risk factor for cancer. And one of the reasons is that there are 2 major tumor suppressor mechanisms that work in the human body. One is what we call the caretaker genes, or mechanisms. And these are essentially mechanisms that will prevent damage or repair damage. They'll repair telomeres, they'll repair DNA damage, they'll repair mutations, and they prevent cancer by essentially preserving the cells, and it's a longevity insurance, because then you also improve aging. However, it doesn't always work. And so we have a second set of tumor suppressor mechanisms, which are what we call the gatekeeper genes, which eliminate and arrest damaged and mutant cells and prevent them from replicating. And that prevents cancer, but at the cost of accelerating aging by depleting the organs in cells. And 2 things can happen, either senescence of these cells or apoptosis, and this will ultimately, by lack of available cells and accumulation of senescent cells, lead to cancer after a while, paradoxically. So having said that, there is a large study called INCIENTI study, which happened in Italy, of course. And they looked at all sorts of laboratory correlates of aging. And one of the things that they looked at is a number of inflammatory cytokines and growth factors, and looked at which one were most associated with survival. And here they found a score based on the log of IL-6 level and the log of soluble TNF-alpha receptor, and they can separate 3 groups of patients with that seems to be working very well, and they validated that in the cardiovascular health study cohort. They developed it in the cardiovascular health study and validated it in the INCIENTI study. The cardiovascular health study is an American one, the INCIENTI is the Italian one. These are also the markers that are associated with physical performance. So here we find the link with our walking speed. IL-6, again, in 6 studies, was found to be associated with physical performance. The TNF receptor, D-dimers, GCSF, and TNF-alpha in all 4 or more studies have been associated with physical performance. So when in that early slide I showed you that inflammation was bad for you, a lot of these genes are associated, these cytokines and elements are associated with inflammation. So right now we can't just take an IL-6 level and say this is a frail patient, but it's an interesting thing. As a caution, I would say that all these biologic marker studies were made in general aging population. Again, these markers are mostly inflammation-related markers, and we need to validate that in cancer patients. I mean, cancer itself can create inflammation. It may or may not matter. Okay. It may be that simply IL-6 reflects the level of stress on the organism and its inflammatory response, and it doesn't matter what creates it. Or it may be that having a cancer messes up these aging-related markers. That has to be tested. So the question is aging reversible? Now, some people have found a very convenient method to preventing aging, and not everybody has the means of the Queen of England, okay? So since we can't have our profile frozen in time, can we revert aging in other ways? Many animal studies have tried to find medications or molecules that prolong lifespan. This is a nice review in Critical Reviews of Oncology and Hematology of a lot of these experiments that have tried to increase lifespan. Now, some of them will delay cancer, others may not. And the first group here did actually delay cancer, but ultimately the cancer was coming. Procaine, interestingly, in that group. The second group did delay cancer and actually decrease tumor incidence. So the first one is calorie restriction. Okay, we know obesity is a risk factor for cancer. Now, in animals, unfortunately, the level of calorie restriction that leads to that decreased risk is 40% less food. I don't know many humans who last very long on 40% less food. Okay, so how translatable to human is a bit difficult. But biguanides, which are diabetic drugs, phenytoin are also drugs that were leading in animal models to that desirable profile. Okay. Now, something that is very interesting is these aging studies had also elements where you were increasing lifespan but increasing tumor incidence as well. And that was selenium, vitamin E, EDTA, melatonin, other things like that. And it's a shame that at the time, the aging researchers were not speaking too much to the cancer researchers. Because the cancer researchers spent a lot of money into a trial that was called the SELECT trial, where they tried to prevent prostate cancer in others by giving selenium and vitamin E. Okay? And they were very disappointed when the results were negative, but the fact is that these animal studies could have predicted that. Okay? So what would possibly work in aging and cancer? Well, there is a very, very interesting set of data on rapamycin and mTOR inhibitors. Okay? So rapamycin blocks mTOR, the mammalian target of rapamycin. And this is a very important pathway that controls the growth of cells and the metabolism of cells in the body. And if you feed mice with rapamycin, you increase their lifespan by 20%. And it doesn't matter if you start early in the life of the mouse or if you start late in the life of the mouse, you still get an effect. Now that's getting very interesting because if it works late in the life of the mouse, maybe it works late in the life of a human when you are... This is mouse in there. What would be the human 25-year-old? This would be a human 60-year-old. Okay? So, interesting concept. Now, what does rapamycin look like? mTOR inhibitors is something we use in oncology. We use temsirolimus, we use everolimus, we use sirolimus. Okay? And this is the French study where they did everolimus plus tamoxifen, and they have survival data. Okay, the Bolero study does not have yet survival data, but the Gineco study does, and I'm intrigued by the tail of that curve. Okay, this is time to progression, and you can see that, cancer-wise, the two curves are fairly parallel. But in that survival curve, overall survival curve, there is a tail that looks interesting. Okay, that would be consistent with the animal data. Now, it's the tail of a Kaplan-Meier curve. It's not very reliable. But I think the data are very intriguing. And one thing that we have been trying to do is to tag to the big adjuvant trial of everolimus some aging-related components to see if we can find a signal in humans. It's not yet out of the box as designing studies. I have a lot of respect for the Alliance CLGB people because designing studies in clinical trial is tough work. It's a very, very, very long process. Another example, mTOR is not the only mechanism targeted, but this is a farnesyl transferase inhibitor called lonafarnib. And it works on the RAS-RAF pathway, which, of course, is a pathway of major interest in oncology. It has in vitro activity against various cancer. It has synergistic activity with taxanes. It is in clinical trials. It has some effect. It's not a wonder drug, but it's being tested. Interestingly enough, it has been used in a geriatric study, aging study. And that aging study was in children affected with progeria, the disease of accelerated aging. And what it did in that category was indeed improve some of these age-related variables that the children had. It decreased the arterial stiffness. It normalized their skeletal rigidity. It had no effect on the insulin pathway. And the effect was, again, independent of the age at which you started treatment, just like the one of rapamycin. So I think these are very intriguing biologic findings. And in the aging and cancer world, we might have common pathways that could be targeted with medications. So as a conclusion, this is how I see the precision medicine of today and tomorrow in oncology. Nowadays, we have a disease, let's say non-small cell lung cancer. We look somewhat at the histology, we test a couple of receptors, and we design our treatment based on that. On the patient side, we look at their ECOG performance status and their age, and if we have the time, we look at their comorbidity. Okay. And with that, we conduct treatment. Now, tomorrow, the molecular panels testing for cancer will become more prominent as the number of targeted drugs improves, as the techniques to do molecular testing improve. Will increasingly do molecular oncology. On the patient side, I think we'll become smarter. We'll understand better how comorbidity interacts with cancer. We'll do a geriatric assessment. We'll assess their life expectancy and hopefully find some reliable biologic markers of functional reserve or aging. And a very important part of it is that there is an interaction between these two. As I've shown, there are common pathways, and diseases that accompany the cancer can influence not only the survival of the patient, but the propensity of the cancer to come back. We know that diabetic patients with colon cancer, for example, relapse more frequently of their colon cancer. True also for other cancers. So this is only the tip of the iceberg. And with a big data database, I think we'll learn more about how comorbidity and cancer interact and what are the markers that we can use for decision making. Thank you. Yes?
I have a question. Have the electronic health records taken an opportunity to use the Rockford Frailty Index or the allostatic load score when you enter your history, review of systems, and then you have your lab results to give you, to quantify some frailty numbers?
That's an interesting thought. It hasn't been done to my knowledge. And it's already hard to get your electronic records to move the lab along with the consultation when you change the date of the consultation. But if the medical records can become smart, I guess that would be feasible. Interesting thought.
Any other questions? Okay.